See the forward button. I first of all thank Dr. Bala for inviting me and giving me this opportunity to stand here and participate in this excellent feast. So straightforwardly, I will just jump to my topic. Just before that, I will just like to point out that the author cannot accept the liability responsibility from errors that may occur from the use of this information. It is up to each clinician to ensure they provide safe anesthetic care to the patient. So just coming to the hemodynamics, this review article published in the 1989, I think was the well-read, and it explained in detail how the hypotension takes place after the spinal or the central neuraxial blocks. As we know that the main site of action of central neuraxial block is the preganglionic outflow fibers, and the sympathetic nervous system is thoracolumbar, whereas the parasympathetic nervous system is craniosacral. And the important thing to note here is that from T1 to T4 are the cardio-accelerator fibers, and from T6 to L2 are the fibers supplying the adrenaline gland, which maintains the circulatory level of the catecholamines in cases of the stress. So when we give the T10 is an important landmark in the sensory level, because any block above T10 will not causing much of the hemodynamic consequences, because still there is sparing of the adrenaline gland, thereby is maintaining the circulating level of the catecholamines. Similarly, any block below T10 will also not cause much of the hemodynamic consequences. However, when the block ascends to T4 level, whole of the adrenaline gland is blocked, and then there is a complete sympathectomy. And if the block ascends further to T1, then it is a high spinal. Even the cardio-accelerator fibers are being blocked, leading to severe hypotension as well as bradycardia. Now, the second thought which was provoked was that, as we know, 75% of blood is in the venous side and 25% is on the arterial side. It was proposed that it is the dilation of the venous system predominantly leading to decrease in preload cardiac output, thereby reduction in BP after the central neuraxial block. And it was proposed that the arterial system is able to maintain much of its vascular tone despite sympathectomy, because it has more aggressive local reflex system, and perhaps it is not responsible much for the hypotension after the sympathectomy. The other reasons for the hypotension after the central neuraxial blocks were like direct circulatory effect of the local anesthetics, like in case of epidural, where a large quantum of drug is injected, and that thereby going into the circulation and directly depressing the myocardium or interacting with other drugs. Skeletal muscle paralysis, again leading to pooling of the blood. Sometimes ascending medullary vasomotor center paralysis, and concurrent respiratory insufficiency, which leads to the acidosis and thereby leading to the profound vasodilatation on the arterial side also. So there were studies by that time which focused that yes, there is pooling of the blood in the periphery, like in the legs or in the mesenteric system, in the splenic system, thereby leading to fall in the left ventricular and diastolic pressure, and that is why there is hypotension after the central neuraxial block. And certain similar type of the studies came which focused their attention that yes, if you use the alpha and beta agonist combination drugs, they basically try to reverse this expansion in the venous reservoir rather than the purely alpha agonistic drug. So thereby it was the recommendation that ephedrine is a better choice of a drug for spinal hypotension rather than the phenylephrine. And in the same article, the cause for the decrease in heart rate was explained either because of the blocking of the cardio-accelerator fibers or because of the triggering of vein bridge reflex because of the decrease in the venous return to the heart. So basically in this article, the main focus was that the central neuraxial blocks decreases the venous return, causes bradycardia, decrease the cardiac function, thereby leading to the hypotension. And in case of pregnant ladies, this venous return can be further impeded by basically gravid uterus pressing over the IVC, as well as if you make them head up positions. And occasionally cardiac arrest during the spinal anesthesia was thought due to unopposed vagal stimulation. And there was one case report which basically reviewed the articles, and they said that bradycardia and hypotension was the first clue in most of the cardiac arrests which were witnessed till that date. So the recommendations came from this article were prehydration as the first line of treatment, left uterine displacement for the pregnant ladies, Trendelenburg position, then atropine for the bradycardia, and ephedrine for the hypotension, and ephedrine was considered better than the phenylephrine. Now, also this article cited that there are absolute contraindication apart from the patient refusal and coagulopathy, hypovolemia, stenotic valvular lesions, cardiomyopathy, severe pulmonary hypertension, congenital heart disease, TOF, Fontan, TGAs, and severe preeclampsia were considered as an absolute contraindication for the spinal anesthesia. Now, what happened after 1990s? These were the times when basically in most of the studies non-invasive blood pressure monitoring was used. After that, there was a tremendous advancement in the invasive monitoring techniques, and then the insight into the causes of the hypertension started change. Now, first such article appeared in the 1997, and then there were a series of such articles which said that prehydration does not alter the incidence of hypotension. Then a review article dealing with the current issues of the spinal anesthesia said that it is not the venous return, but it is the arteriodilatation and the fall in systemic vascular resistance which is predominant main cause for the hypotension. And they found that even in the patient with low ejection fraction, the cardiac output, cardiac performance was enhanced after the spinal, and there was just modest fall in the CBP and pulmonary vascular resistance. So the shift was now shifting that it is not the venous return, but it is the arterial vasodilatation which is the main reason for the hypotension. The second issue was that crystallite does not help in preventing the hypotension. Some long-acting colloid may be beneficial. And the third thing was that phenylephrine and adrenaline, they were equally effective in preventing the hypotension, but with one rider that if you tend to raise the blood pressure too much, then perhaps there was fall in the heart rate with the phenylephrine. So in 2003, one very interesting article appeared in a series of 60 patients where the spinal was given to the severe pre-eclamptic patient, and they found that the hypotension was much less than the normal pregnant patient. So this was basically major shift and provoked the thinking why this is happening. From the same article, the people started giving spinal anesthesia to the patients in the cardiac patients, where usually it was thought that it is totally contraindication, like the patients with mitral stenosis, patients with the aortic stenosis, patients with the cardiomyopathy. The people started giving spinal and just trying to do under the all type of the basically monitoring. Now, in this article, the authors tried to study the various hemodynamics after the giving spinal eclamptic patients, and what they found that there was modest fall in the high blood pressure, no vasopressure were given, and there was substantially increase in the stroke volume and cardiac output in the pre-eclamptic woman after giving the spinal. So it was accompanied by the editorial, and the editor said that perhaps it's the high time that we start concentrating on the cardiac output rather than the blood pressure after giving the spinal to the eclamptic women. Then came the concept of giving prophylactic phenylephrine infusion in the prevention of spinal hypotension. And what they found that when the prophylactic phenylephrine infusion was given in titration to the heart rate, they found that the blood pressures and heart rate were better monitored, just with modest decrease in the cardiac output. And in 2009, many articles appeared on this issue. One of them addressed the issue of ephedrine versus phenylephrine, and it said that actually the ephedrine is bad for the fetus because it crosses the placenta and causes the increase in metabolism in the fetus and thereby decrease in the pH in the fetus, whereas the phenylephrine was safe in case of the pregnant woman. So another article talking about the colloid versus colloid preload versus colloid co-load in the spinal anesthesia up to the level of T4 found that both the strategies does not prevent the spinal hypotension in any way. So In pregnancy with severe pulmonary artery hypertension also, the people started giving spinal, and what they found that early plant delivery and regional anesthetic should be the technique of choice even in the severely pulmonary hypertensive patients. But remember, these patients were all monitored by the invasive blood pressure, and they were used prophylactic phenylephrine infusions. So in 2009, a very interesting, thought-provoking article editorial appeared, which said, hypotension in obstetric spinal anesthesia, what are the lessons from the preeclampsia? And what it said, using prehydration, anti-G suits, pelvic tilt, everything has failed disappointingly in preventing the hypotension. Marked bradycardia with reduction in cardiac output and severe hypotension due to autocable compression in supine position is relatively uncommon reflex known as supine hypotension syndrome of pregnancy, and it should not be related to the spinal. It is an independent entity and it can occur even without the spinal. Undoubtedly, IVC is affected by the gravity uterus, but it remains partially occluded even in the lateral position. Link between the changes in venous behavior and hypotension was inferred in the previous studies rather than directly proved. And this is also true because if you see the hepatic drainage, it is above in the IVC, where the IVC is compressed from the gravity uterus, and IVC, this hepatic drainage contributes to near about 50% of the return. So what they said, that the venous turn is not impeded, though it is being maintained at a higher pressure in the lower limbs. Then the view that CPP controls the cardiac output suggested by Guyton and colleague is for the isolated heart, and it should not be applied for a basically loop circulation. A recent helpful view is that volume in the venous system is more relevant than pressure, and that venous access is important in regulating the factor on venous side of the circulation in a loop circulation. What does it mean is that Guyton did this experiment where basically he altered the preload by altering the reservoir height, and when you basically plot the venous return and right atrial pressure, you find that as the right atrial pressure increases, the cardiac output increases. But in a looped system, which actually the person has, the things are different. Here, every regulator in the body is trying to regulate the cardiac pump, that is the basically pump. So the function should be in relation to the cardiac output. So what it will be, when the cardiac output is high, your venous return is obviously high because the pump is moving this loop much faster, and at that time your right atrial pressure is basically here, and the right atrial pressure is somewhere here. And as your cardiac output declines, the venous return also declines because now the mobilization in this loop is decreasing, and this right atrial pressure tended to increase because now the right atrial pressure is increasing because the suction effect of heart is going away, and it will finally reach equal to the mean systemic filling pressure. So that means in a body, two factors of venous turn and cardiac output are linked, and neither is the cause or effect in the changes of cardiac output or venous turn. They are merely the coin of the same side of the same coin. So what does it mean? So baroreflex fails to maintain arterial blood pressure after spinal due to non-release of sympathomaines in the circulation. So the use of sympathomimic vasopressor to sustain arterial tone and thus arterial pressure should be the most important strategy in the safe spinal anesthesia, and more studies calibrate this strategy in the pre-eclamptic women which are hypovolemic also and which have high arterial tone also. So after that, there were reviews on congenital heart disease and the pregnancies, 2 reviews, and they said that the regional spinal is quite safe in case of the even congenital heart diseases when invasive pressure was monitored and blood pressure was taken care of with the help of phenylephrine infusions. So the guidelines were in the 2011, the guidelines came that the most frequent cause is basically the systemic vascular resistance fall, and it should be maintained by the prophylactic phenylephrine boluses or infusion titrated to the heart rate. And at that time, one other group came up which started using very high spinal doses up to near about 37.5 milligram, 8 ml of spinal in the cardiac surgery to block whole the spine up to the T1 level. And what they found, the hemodynamics were quite stable and nothing to worry about. The same group was basically associated with us, and we did studies in basically in severely tight mitral stenosis patient who were undergoing IVR, and we basically monitored these patients invasively as well as echocardiographically. They were on all sorts of drugs, and what we found that in these patients, what you find that heart rate declined after giving the spinal, the stroke volume index at various study intervals were higher in the spinal group, the cardiac index was maintained, and pulmonary artery bed pressure was also equal. In these patients, no fluids were infused during the spinal, and this study was lasting for the 30 minutes. And how we could see that what is happening is across mitral valve, tight stenotic valve, when the heart rate is high, it is just transmitting only the VTI of 33.2, and the moment the heart rate is controlled, VTI increases to 78. That means basically the flow across the mitral valve improves much nicely after the spinal rather than when the spinal was not given. And this article even recommended that surgical sympathectomy should be done in the refractory arrhythmias, and perhaps it is the modality of the choice where everything fails in case of the arrhythmias. So, what is the conclusion from these all? There is now paradigm shift from the preload reduction theory to the afterload reduction theory in a loop circulation concept. The vasopressure should be the first line of management in titration to blood pressure and heart rate. No myocardial depression with CN block occurs, and bradycardia usually is because of the overactivity of the vagus, which should be responsive to the atropine. With IBP monitoring and prophylactic phenylephrine, or for that inopressors, depending upon the case to case, there is no absolute cardiac indication for the spinal blocks. Understanding the pathophysiology and drug interaction of the various comorbid conditions are important before planning for CN block. And CN block related hemodynamics alterations should stabilize within 20 to 30 minutes of the spinal block. So if after that also if they are persisting, then you should think else rather than the spinal for it is the cause, because in a recent article still the cardiac arrest do occur under the spinal anesthesia, but again there is a paradigm shift. Now the death under the spinal anesthesia are less as compared to the GA, and the death are not in the early phase of the spinal, but they are in the late phase of the spinal, and perhaps it is because of the miscalculation of the volume which the patient is losing and the volume which the person is infusing, because they try to maintain, I think, more of the blood pressure by the phenylephrine. So you have to strike a balance, and you have to understand the pathophysiology before what you are doing. Thank you very much for your attention.